Good afternoon, everybody. Thank you very much for joining us today here at Healthmonics in our next section of our webinar series. Today's webinar series is going to be about MVPs and MIPS cost, how they interact with each other, how you want to take a look at them moving forward, what you may want to do this year and next year, and we're going to dig into a lot of that today. So there is a lot of information that we're going to share, but I do believe we will have some time for some questions, so feel free to ask some questions. I am joined today by none other than our President and CEO, Lauren Patrick. Hi, Lauren.
Hi, Mike. We're in the same room today.
We are, which is scary, so she could point at me every time I'm not doing something right. But we are here today to help you guys out and see where we can teach you a little bit about what MVPs are and see if you're interested in how to report them moving forward. All right, so a little bit of what we're going to go over today, the benefits of reporting MVPs, cost measure exposure, so what does that look like, as well as a little bit into cost attribution. We have done a number of these webinars in the past where we can link some information on follow-up email today. If you want to dig a little bit more into MVPs or into cost, we have full webinars that are dedicated to both those subjects. A little bit of housekeeping here. There is the ability here to ask questions as well as there are handouts on our form as well. The handouts, you'll be able to see the entire document for the slide presentation that we have, as well as I will send that after the call this afternoon. Now, I can't go without saying, because my marketing team told me to have to say this, so Savannah, here you go. Please stay tuned to the end of the call today for a special offer on our cost program. All right, so what are MVPs? I'm going to go through most of these slides, but I'm going to have Lauren jump in and do some extra explaining and deeper dive, as well as try to answer some questions as we go along today. So MVPs were created to simplify MIPS clinician experience. Their main objective here is to reduce burden and to better inform patients' choice in selecting clinicians. So those goals have been around in the past when they said introduced physicians portal back in the day. Never really came to what they really wanted it to do. So the biggest problem is you were comparing a dermatologist to a primary care doctor, and that really wasn't working. So you're catching the patient voice, so understanding what the patients are saying, as well as helping clinicians and practices move towards APMs. So CMS would like all providers to be in APMs or some type of value-based program by the year 2030. So that's not as far away as it seemed just a couple months ago. We started because clinician concerns that MIPS doesn't allow for sufficient differentiation. So once again, back to those specialties. And then their focus was really to drive everybody from MIPS to MVPs. They haven't announced a date or a time that they plan on subsetting this. There's kind of suspicions, but the plan is to move away from MIPS into MVPs as we move forward. So how are MVPs made? They connect measures and activities across the 4 MIPS performance categories. This is the part that should be very familiar to everybody that has been reporting MIPS for a long time, as well as even back in the day to the PQRS times. You're going to have your 4 categories: your quality, your cost, improvement activities, and promoting interoperability. Currently, there are 12 pathways to report on, and there are a number more that are being added for 2024. They do incorporate a set of administrative claims-based quality measures, as well as those ECQM, CQM measures, and they also have they also include promoting interoperability to the same exact measures and as before, as with MIPS. Sorry. So, am I required to report MVPs? Well, the answer is no. No, you're not required. Not this year, not in 23, not in 24, as far as we could tell by the proposed rule. but they are available for voluntary reporting. It could replace your traditional MIPS scoring. It could be a real big benefit to you, and that's what we'll go over a little bit today. But right now, you have the opportunity in 2023. This is the first year you could report MVPs. You could do it through a system like MIPS Pro. You may have some difficulties through an EHR or through other mechanisms to report them, but we have it here at HealthMonix, the ability to report MVPs. 2024, they've made a lot of proposed changes to the measures to make them a little bit better. I think what they realized when they first came out with the 2023 measures is that they are a bit, they didn't have as many choices within the MVPs that make sense for people to report them. And then 2025 is a target really that they're going to be pushing more people towards. And then by 2026, if you're going to report MVPs, they're going to force you into what's called subgroups, which we'll get into, for multi-specialty groups, where they're intending you to report MVPs that are really related to your type of practice and type of work that you do. You have any insight into that, Lauren?
Well, I was going to say beyond that, it's not only that they're going to be moving multi-specialty groups into MVPs, but it sounds like they're going to start requiring, in particular, multi-specialty groups to break off into subgroups and have different specialties within those groups report measures and activities that are relevant to that particular specialty. That's really where they're going, and a lot of the focus is on getting providers to report the specific measures and activities that are most relevant to their specialty. And in particular, they've seen the issue with multi-specialty groups.
Thanks, Lauren. So as we move on, a lot of this is familiar to the people on this call, hopefully today, being able to take a look at how MIPS is separated. So the whole program is MIPS, right? But then there's multiple ways to report it. There's the traditional MIPS. There's APP, which is the APM performance pathway. So those are for your ACOs. And then there are MIPS value pathways, which is the new one that has been introduced in 2023. Through traditional MIPS, you have all those options: group, individual, APM entity, as well as virtual group to report as. You can see what it is for the APP. Currently, it's only open for ACOs to report at this point, but they will be expanding that as we move along. And then with MVPs, you have the options of group, subgroup, and individual for reporting. You can't combine like you can with traditional MIPS through an APM entity or a virtual group as of right now, but those will change, I'm sure. So what are the benefits of reporting MVPs? So there are a couple benefits here. The first one that we talk about is a more connected assessment of quality care, measures and activities targeted to meaningfully focus, as well as connected assessment of care provided. Really what they want to take a look at is these foundational measures, utilizing your promoting interoperability and your population health tools across the platforms, and then adding quality improvement activities and costs that make sense to bundle together. So what you see here, for instance, is the MIPS, the MVP for diabetes prevention, and you can see the questions that are associated with it, from everything from the quality through improvement activities and costs, have to do with diabetes and have to do with those types of patients that you're seeing. So there's not questions, you're not being asked in this measure, did you have your flu shot, right? Because that's not making sense on the diabetes side. You're not going to have improvement activities that aren't associated with this patient population. So really that's the whole plan, is to get you into the mindset that you are only needing to do things that are associated with this way you treat patients and your specialty. The next one is streamlined, reduced set of measures and improvement activities. As you can see here, there are a lot of differences between traditional MIPS and the MVPs and what's needed. There is a reduced amount of measures that you must report on, as well as some of the other capabilities, and we're going to definitely get into more on the cost side towards the end of this call. But this is Lauren's graph here, so I'm going to let her talk a little bit about what she thinks on this slide to share.
Yeah, so if you can find an MVP that's A, relevant, and B, has measures that have decent decile scores, and that's been a biggie this year, then moving to an MVP is great because you're really reducing the burden of reporting. You're whittling down your quality measures from 6 to 4. You're only looking at one specific population measure that you get to pick. And you do less reporting of improvement activities, costs we'll talk about in a minute. So yeah, in general, it really does help in terms of streamlining what you're doing in the MIPS reporting world.
So then the third one here is a chance to prepare for enhanced performance feedback. This has been something that has become more important as CMS is changing a lot of what's happening with feedback currently in the process and moving forward. But the concern has been clinicians aren't compared to their peers, right, to similar clinicians. And that doesn't make sense if you're seeing sicker patients or you're seeing patients in a different setting than other people and you're being compared to them. It doesn't make much sense and it doesn't really do, the data justice that they're getting out of it. Feedback will be based on a specific MVP, so you only be compared to those that are reporting that MVP, and it is more relevant and more targeted measures for you. So when it comes to performance feedback, I am going to lean once again on Lauren to discuss kind of what that looks like and what CMS is really trying to get out of it.
Right, so what they're trying to do is compare cardiologist to cardiologist, endocrinologist to endocrinologist, etc. They're really trying to focus in on, if I'm looking for somebody to do my shoulder surgery, and I want to look at quality of care and cost of care, how do I find similar benchmarks? Between the fact that they are going to benchmark within MVPs rather than the general physician or clinician population, and the fact that they really are working towards promoting the care compare a whole lot more to the Medicare population, I think that looking at this feedback and understanding how you can kind of excel in terms of what your patient population or your potential patient population are, is really going to get impacted as we move forward. That's really where CMS is going, is trying to put out there in the world comparisons that I know that, I have friends and that ask me, how do I know who the best doctors are? And CMS is working to make, it used to be physician compare and hospital compare and SNF and they used to have several, they've combined them into care compare. They've worked to make sure that that everything is out there and usable, and they're increasing the measures that are being shown to everyone. They haven't actually shown scores yet on the care compare. You can get scores through the public use files through CMS, but in terms of what they're showing Medicare patients, you go to care compare and you can see a lot more measures than you used to see. And right now, I think they show like 1 to 5 stars, but I can see eventually they're going to be showing people scores as we move forward.
Great. So another reason, and this has always been the reason to move forward with these programs way before they're mandatory, is really, why should you report the MVPs now, right? An opportunity to become familiar with them. If they're going to make them mandatory in the future, be the first one in line. Don't be the last one that's trying to catch up at the end and make those changes. As we said, CMS is going to sunset the traditional MIPS. CMS is also optimizing MVP participation starting now. So there's benefits to reporting MVPs, as well as one of the best part of it is that you can report as an individual, you can report as a group in traditional MIPS. You can report as an individual in MVPs, you can report as a group in MVPs, as a subgroup in MVPs, and CMS will take the highest of all of those scores, and that's what you get. So there's no harm in trying to report an MVP right now, and it could only be beneficial for you. And we'll get into some of those reasons as well. So the next thing is the potential to reduce reporting burden across the program. So as you can see here, the average provider spends $12,811 per year for MIPS and everything around the value-based care programs, and whether that is consulting and their registry, their EHR, whatever it may be, they're spending a lot of time. And probably number one, when you really dig into it, is their time, making sure they're documenting correctly. So most of that is documenting quality measures, collecting data and appropriate, making sure it's in the right area, making sure it's being, that you could read that data so that you can get your scores of what it needs to be. So this is the time to start considering focusing some of your effort, not all, right? But it's 30% of your score. And it's equal to, for many of you, the same score that you'll be getting in quality. So being able to pay attention to this and really dig into it is important going forward. So as you can see here on the right-hand side, their main goal really is to start combining those different domains when you're talking about patient populations together across the MIPS world, not even in MIPS, so outside of MIPS. You're talking about your HEDIS measures. You're talking about your quality measures that you're doing with some of the private payers, your Medicaid things, and the new items that they're introducing, new things that they're introducing through their final rules and their proposed rules. They're trying to put everything together. As you can see, they're really bundling these measures so that they are making an impact on these patients.
Right. So what CMS is really focusing on doing is setting up one set of universal measures, the Universal Measure Foundation, one for adults and one for pediatric care, and using those same measures in all of the programs. Because the problem we have right now is each program, MIPS included, has taken these measures and tweaked them a little bit. And so bringing them back together is becoming more and more of a focus, so that if you're reporting a measure like colorectal cancer screening, once you've got that measure set, you can report it not only for MIPS, but for other programs, both within CMS and probably to your private payers as well for a measurement and analysis.
So question, a number of the questions that actually have come up have been around small practices. I want to get into small practices in a minute here, but for this webinar, just for you guys to know, we've done a ton of these webinars in the last couple of months, and they are all on different levels of experience with these programs and so forth. We do have beginning webinars on MIPS and what is MIPS and what is cost category and things like that, that I will link in a follow-up email. But we're really going to stick to the MVPs, and that is a higher level of understanding for this webinar. So do small practices have the flexibility in reporting an MVP? Just as in traditional MIPS, small practices are going to have that flexibility. So you're still going to get the 6 bonus points. You're still going to get the 3 bonus points for quality measures that lack a benchmark. So the larger groups don't get those, right? So small groups are 15 and under. Large groups are considered 16 or more. You also get still the automatic reweighting of promoting interoperability within an MVP. So any of those small groups that are currently getting that with MIPS will also get that within the MVP. And then the one thing that small practice have is that you'll actually be doing the same amount of improvement activities. Larger groups actually benefit, and they have to do the same amount of small if they're in an MVP. So that's a big benefit. It's a benefit for the larger groups that are there. But more or less, you will have the same abilities for the same categories and the reweighting and how that works that you have in traditional MIPS that you do in the MVP. So there isn't much of a concern when it comes to that. Can a clinician report multiple MVPs? Yes, clinician can participate in multiple ways to report multiple MVPs. You can report as an individual. You can report as a multi-specialty group. There are also subgroups as well that you can report. You can report them as an APM entity. And as well, on top of that, if you are in multiple practices, you can report an MVP in all different practices. So for an example, the entire group of internal medicine clinicians can participate as a group to report the optimizing chronic disease management, but then you could take a subset of that specialty group and report the advanced care for heart disease MVP. Can a clinician participate in multiple subgroups? Well, this goes back a little to what I was saying before. You could only participate in one subgroup for the practice that you're in. But if you're in 5 different practices, you could be in 5 different subgroups. So CMS takes the NPI and the TIN combination, so a provider and practice combination, and that is, you're only allowed to do 1 subgroup per that combination. So as you can see here, 1 clinician, 1 subgroup, 1 clinician, 2 different practices. They have the ability to do a subgroup in each of the different practices that they have reassigned their billing rates to.
However,
the
reason you can only do 1 subgroup within the reason an NPI, an individual practitioner, can only do 1 subgroup within a practice is a technical limitation from CMS. The original proposed rule said that a clinician could be in multiple subgroups within their group. Having said that, there was a technical limitation on CMS's part for 23. I have a feeling that same limitation will exist for 24. Eventually, the plan is to allow a clinician to participate in multiple subgroups.
Wow, you really need a fancy registry to be able to help you out with that. All right, I had to get Lauren to laugh for a second there. Sorry, guys. All right, so how do you improve your score through MVPs? What does that mean? You know, really, in the end, we want to reduce the burden. You want to move forward with it, but you don't want it to impact your scores. As you've seen, CMS is planning this year at 75 points. Next year, it's moving up to 82 points to avoid the penalty in MIPS. So those categories are very, very high, and you need to get above those to avoid those penalties. So taking whatever action that may be when it comes to reporting options can be very helpful for you. So how to improve your score through MVPs, selecting the right MVP. A couple of the questions here were about MVPs and making sure that you're in your specialty, but it doesn't necessarily mean that. It's currently not in 2026, which we talked about earlier, where they're going to force you into MVPs that are what your specialty is about. But there's ability here now for any specialty can report on any MVP currently. And if you could find 4 quality measures and you could do the improvement activities, it might benefit you to take a look at those MVPs. Understanding all the requirements. Do you need, do you have 4 measures? Is there a measure in there that has a high priority or an outcome based? Are your cost measures that you are associated with last year, are they currently in the MVP you're looking at, or can you avoid that? Collecting and integrating data, ensure that your practice has necessary data. That is most important when we work with our clients here, is that you could do all the greatest work in your EHR, but if you don't click the right button, you're not getting credit for it. So utilizing a registry, being able to see those gaps in care throughout the year and understanding what you're missing can really help you when it comes to integrating all of your data into being able to report for an MVP. Review current performance and benchmarks. Once again, go into the QPP site, go pull your 2022 information that was released over the summer, look at it, understand what measures are you being attributed, understand where you stand compared to your peers. It's all sitting there right for you. Work with consultant, work with Healthmonics to be able to understand what that looks like and what type of MVP and if it's ideal for you and so forth. Develop quality improvement initiatives. It's September now. We have people that don't think about MIPS until reporting season starts, but as always, I've always recommended getting started with MVPs as soon as possible. Getting started with this quality stuff as soon as possible. Set your plan for 2024 if you haven't already. You can understand what the measures look like. The final rule will be out sooner than we think, and we'll have the opportunity here really to put yourself in position to be prepared and to beat out the competition. Even though it's not competition, the competition, you need to score higher. So how do you decide if you should report an MVP? I really don't have terribly a lot on this screen except for all the current MVPs because I didn't have it in another area of the presentation. So here are all the current MVPs that are available. This is a snapshot from CMS. So those appendices aren't going to be linked on our page, but if you go straight to the QPP website, you'll be able to see what it is through the appendix. On the Healthmonics site, we do have a list of all of the MVPs, and the information that's needed about what's inside the MVP.
So you can see that the MVPs really don't cover the full set of clinician types that are in the world. It's pretty limited right now. CMS is actively seeking organizations to set up additional MVPs. And there are a lot in the works right now. But until they really get to full coverage, they're not going to be able to enforce everyone using an MVP. So that's sort of one of the limitations of moving forward with full MVP reporting.
All right. Before I hop on to the next question, the next page, I did want to introduce a quick poll for everybody. We just want to find out a little bit more about who's on this call and where they are in their level of understanding of MIPS. So if you could just take 2 seconds and respond to this, I would very much appreciate it.
It won't let me respond.
Lauren's trying to respond as an expert, everybody. Trying to keep her away from that. If everybody get their answers in, give it another 10 seconds or so. Great. For those that are experts, give me a call. We always are hiring. No, I joke. But thank you very much for that. So it looks like to me on here, most people are in the beginning to intermediate. So I appreciate that response. But then again, you know, there are a lot of people in this group that don't have the knowledge of MVPs as of right now. But moving forward, you know, this is where you're going to be able to get your information. So thank you for participating in that. Lots of great questions coming in. A lot of them are very specialty specific or practice specific. So if we can't get to those answers now, we'll try to answer to you after this meeting or by early next week at the latest. All right, so here is an example of the wellness MVP. This is one of the better MVPs for 2023 reporting. The reason that is because you can see on the right-hand column, you're looking at there's no measures that are topped out and no measures that are capped at 7 points. On top of that, you have a number of high priority / outcome measures that are available for you. And there are a bunch of measures. So you're not just trying to choose between 6 measures. There's a number of measures here that you can choose and a number that you're probably pretty familiar with, as there are very common measures in this group as well. So this is an example of one of the MVPs. Other MVPs here have claims-based measures in them. Some of them have QCDR measures in them, which are specialty specific, non-CMS measures that are incorporated in this. But this is an example of one of the MVPs, all of the measures that are associated. Cost measure attribution. So how does that work? We're going to spend a minute on this. Probably going to lean a little bit on Lauren for this because she's the cost guru here. But cost measures contain 25 measures available. They have the total per capita cost, which is the population-based measure that covers all primary care. There's Medicare spending per beneficiary. Then there are the 15 procedural episode measures, 6 acute measures, and then the 2 chronic condition measures. I think Lauren could give maybe a minute or 2 background of what they're thinking by spreading this out like this.
Right. So again, what they're trying to do with cost measures is they're trying to cover the entire universe of clinicians. And they're trying to make MIPS more of a program where it's measuring not only quality, and we can have a big discussion about whether it really measures quality, but also the cost of care. So what they've done is they've looked at what types of treatments cost the most in the US for the Medicare population and tried to build cost measures around those that can give them and the clinicians feedback on how much it's costing for each different kind of care. They've built some pretty complex algorithms to attribute these measures to clinicians across the US. And in 2022, it was the first year where people saw a lot of these measures getting attributed to them. So there was a lot of surprise when when clinicians got their feedback reports, in that there were a lot of measures that were attributed to them based on these complex algorithms. And they're like, well, gee, why am I getting attributed the total per capita cost when I am a dermatologist? Or why am I getting attributed the Medicare spending per beneficiary when I am a radiologist? And so we're just pointing out here that there's a lot of complexity. And I think Mike's next slide, drum roll please, shows you an example of an organization that has a whole lot of measures. Now, this is obviously a bigger organization, but they got all of these measures attributed to them. So if they really want to dig in and do some work, they've got a lot of work to do. They've got to figure out, because each one of these measures gets equally weighted in terms of your cost score. Just like in quality, when you have 6 measures for traditional MIPS or 4 measures for MVPs, here, however many measures get attributed to you, they average your scores out. So you could be like, holy moly, I've got a lot of work to do to understand all of these and figure out how to attack my cost score. So what we're thinking is, if you move into an MVP, MVPs have a very specific number and specification of what measures are attributed, and you can avoid a lot of this. So that's one big reason to think about moving to MVPs sooner rather than later.
Good.
Does that make sense?
It does, and that's a good segue to our next section where we discuss cost, measure, exposure. So this is exactly what Lauren was just saying. Inside an MVP, they're composed of the population health measures, the quality measures. You have to have the one outcome measure, the high priority measure, if it's not available, promoting interoperability, improvement activities, and costs. And what's nice is that you limit that exposure. So take that example of that group that you just saw on the previous page, right? And understand that that group needed to, or was getting attributed and counted for up to 10 different cost measures. Well, that's really, really hard to, attack all 10 of those cost measures at once, right? Averaging them out, you could have poor performing ones that bring you way down on score. If you do an MVP, it limits the number of measures that you're exposed to as a practice. So for instance, if you're doing here the optimizing chronic disease management, the only cost measure associated in 2023 is the TPCC. You're not going to get hit with MSPB. You're not going to get hit with any of the other specialty measures if you have enough attributed patients. So your goal is to really understand TPCC and how you can improve those scores. Even better on top of that is to take a look at measure, for instance, let me pick one out here, improving care for lower extremity joint repair. Those providers that are reporting that as a group, whether you're a specialty group or a multi-specialty group, you're going to probably have TPCC hit you because you might have PAs that work there and MPs that work there, or you might be considered, your specialty might be considered primary care according to CMS. By doing this MVP on the lower extremity joint repair, you are narrowing it down to knee arthroplasty and elective primary hip arthroplasty, really giving you the ability to only be counted or exposed, as we're using here, for 2 measures.
And somebody just asked about case minimums for the MVPs, and the case minimums are the same for MVPs as for traditional MIPS.
So MVPs are designed to align with specific clinical conditions and patient populations. So unlike traditional MIPS, where there's just an array of everything across the board, as I said, for years, Lauren's been doing it longer than I have, but I've been doing this for over 10 years now. And still people are asking, did you have your flu shot? Do you smoke? Questions that they sit there and go, okay, maybe these are great healthcare questions, but what does that mean to me and my specialty? That's always been the biggest problem with MIPS. And those usually are the easiest questions. So you end up just doing them anyhow. So really what it is to bring this in and really understand the quality measures and the cost measures that are more closely aligned with the work that you're doing in your practices. So specialty groups and specialty organizations are going to make out with these MVPs, and they're going to get out of them what they put into it. So for instance here, what you see on here, you have a multi-specialty clinician practice, right? Through traditional MIPS, you're gonna have these 3 cost attributed measures. But for these other ones, so if you choose MVP1, you're just gonna have MSPB. If you choose the other MVP for advanced cancer care, you just have TPCC. You're limiting your full exposure to each one of the categories here. So dig into a couple of the examples here. Here, this first one is practice that reports traditional MIPS versus the advancing cancer care MVP. So once again, just remember that you can report both, especially for the way that some of these cost measures come out, where you could have a good idea for a cost measure, but you don't necessarily today know the exact score. CMS also removes measures, they truncate measures, they take out benchmarks, they do a lot of different things with measures. So giving yourself the most options when you report at the end of the year can be very helpful. So you can report both traditional and the MVP at the same time, and CMS will give you the highest score. So what you can see here in traditional side, this group here has a total per capita cost 8.2. Diabetes, their score is 4.1, and their Medicare spending per beneficiary is 5.5. So in traditional MIPS score, they're going to get 17.8 out of 30, which gives them a 17.8 score in cost, right? That's a little bit above average. However, if they were to do the advanced cancer care, the only measure that's counted for that MVP is the TPCC, which is the one that they did the best on. So now you add up all together, there's only one, you get 8.2 over 10, and now your score is a 24.6. You just gained almost 7 points, my math's good today, almost 7 points in that category. And now we're moving up to 82 points moving forward to avoid the penalty. 7 points is a drastic spin in what your score can be.
Somebody also just asked a question about if I'm in a subgroup, what cost score do I get? And the cost scores are still only calculated at the group and the individual level.
Cool. Yeah, same with promoting interoperability. Promoting interoperability is also benchmarked at the entire group level. You can't separate those out as well. Good question and good answer. All right, here's another example here. So a practice that reports traditional MIPS and the improving for lower extremity joint repair. You're looking at the same type of thing. What you're showing here is on the traditional side, all of those scores add up to a 26 over 40, and that leaves you at a 19.5 points for traditional MIPS. However, if you were to do the lower extremity, this is the one example I basically was giving a couple minutes ago, you only are going to be exposed to those 2 measures. There's your total points as well as your total score. Now, let's say, for instance, and let's be the devil's advocate or look at the negative side of it, and let's say that it was opposite and your improving care, those 2 measures were lower than your TPCC or MSPB. Well, then if you do an MVP, your score would be lower than it would be under traditional MIPS. So it's really about doing both right now, understanding both throughout the year to understand kind of where you are and what you need to do and what you need to look at. Not everybody is going to be, let's go MVP, and not everybody's going to be, let's go traditional MIPS, but everybody can be both. And if you do both, there's a better opportunity for you to make it out at the end. So how do you find outliers in your data? So we have a program here, it's called MIPS Cost Analytics, and it provides you with ways to look for your outliers in your data, ranking providers or patients to see the highest and lowest costs in each list. So it's going to show you your providers, patients, certain service categories, cohorts. It's going to drive into each one of those data so you can see what those highest scored patients, highest performing providers, highest performing patients, lowest performing, who's costing you the most in this category. You can review external providers. You want to take a look at, okay, after they had their knee arthroplasty, they're going to go to a skilled nursing facility. Well, this skilled nursing facility keeps patients twice as long as the other. This skilled nursing facility lets people go early and they end up getting readmitted to a hospital, which all comes back to costing you in these attribution models saying that this patient costs Medicare more, and therefore you're going to get dinged for it. Identify patients receiving appropriate preventative care. Which one of your providers aren't going to their primary care provider? Which ones aren't getting their A1C checked if they have diabetes? Which ones aren't getting their flu shot or their pneumonia vaccine? How can you look at that, and how can you make better choices for how you interact with them and talk with them and make sure that they're going to see their primary care providers? Reviewing patients with high or low HCC scores. A lot of it comes down to making sure that you accurately are billing for these patients. If someone's really sick, make sure that everything is calculated correctly in their HCC score, or you can, to CMS, it looks like you have a perfectly healthy patient that got sick, and now there's no risk associated with it, and therefore it hurts you the most. So each of these categories provide you the opportunity to analyze your data, make changes in your practice, and make changes, work with individual providers. The people that we've worked with have really wanted to work. The providers themselves want to look at this data to understand what's going on with their practices, with their patients, and know what changes need to be made to improve. So a couple of the screens, we'll go through that, and then it looks like we do have a little bit of time for questions. So Lauren, get ready. All right, so here what we have is a measure summary. You got to see this a little bit ago. This is a smaller group. What you can see here is that this group is only really going to have two potential measures. You can see the bottom three there that have a number of eligible instances in there don't meet the case minimums. So only the first two. But the one thing that I really want to draw your attention to here is that this group has 3,000 plus patients that are being calculated for the total per capita cost, and they only have 21 patients that are in there for the mastectomy. So the big difference there, what you see is that they have the same impact on your score, the exact same impact on their score. So doing work and figuring out how to better those 21 patients may be a good opportunity for you, rather than spending your time and really trying to figure out what to do with all 3,000 of those patients. So summary by provider, our program gives the ability to really dig into these measures. You see by provider. One important thing I like to share with people is that there is a really big difference between what is being paid inside your tin compared to what is being paid outside, or the overall. For some of these, you see it's not too big a deal like the first two, but the third provider is bringing in $1,500 per patient in their tin, and the charges that are being associated and attributed to them could be up to $23,000 outside. So it's not about revenue in this case. It's about cost. It's about what it is for your patients. You can drill down to the the provider level. So here in TPCC, this is a provider level, shows each of the patients, how much they're being attributed to them in TPCC. That's done on a monthly basis. Number of candidate services rendered, what's the total cost to that patient, and where is that compared to your the overall cost inside and outside of your tin. Here's an example of episodes for this one individual provider, and showing where it is from a risk score and the month that are associated with. So you can see here, are they being fully tagged as the provider for this patient, attributed, or is it a partial? And you can see a lot of the differences in here for this. So the important parts are to know your measures that are attributed to your practice in 2022. So I highly recommend that you go in and you really understand what was in there. Go in the QPP, find out what attributed patients you may have, find out what attributed scores you may have, and then get to work on how do you improve those scores. So reviewing the cost measures in a possible MVP is really important. Determine which measures might be in an MVP. You can lower or raise your scores. I gave you both examples. Review quality measures, benchmarks, and scores that are included for measures. And then, it is more complex, but start thinking about subgroups and how can you split your providers up to maximize not only your scores, but also your ability to understand where you need to go moving forward. So that is close to the end of my slide deck, and then we're going to get to questions. I only have a couple more things. We have stay tuned for the next webinar coming up in October. We're going to do a lot more on MVPs, on cost, on MIPS, and we'll have that out to you towards the end of next month. And then, as I stated earlier, you have the ability here now with the MIPS Cost Analytics. It's a buy one, get one free license voucher special for you. So if you purchase 2024, we will throw 2023 in currently at this point of the year. So just give my team a call. You could give myself a call, email me. You'll have all my information after I send you the slide deck. If you don't have it already, you'll have the ability to take advantage of this cost analytics score. So for more information or to use the voucher, feel free to give us a call. You could talk to me or any one of my associates. There's my information. That's my direct phone number, my direct email. Please feel free to leave a message if I don't pick up. I am usually pretty good at getting back to people. And to sign up or to get ready for it, you can go to mipspro.com. So just give me a minute here as I am looking through some of these questions, and Lauren and I will see what we can answer for you. All right. All right, Lauren, anything stick out that you want to go to first?
There's a lot of questions around specialties, and I think that there was a slide where we listed the 12 current MVPs. Unfortunately, as I said, there's not a lot of coverage there. If you're looking for an MVP for your specialty, you might want to reach out to your specialty society or your board and ask them if they're pursuing something. You know, in particular, I see dermatology, ophthalmology being listed as areas where potentially they could put together an MVP. You need a cost measure. That's the biggie. In both of those cases, I think for ophthalmology, we do have cataract, and for dermatology, we have melanoma. That would work. And what's kind of nice about that is if you're not a cataract ophthalmologist, or if you're not a dermatologist that does melanoma resections, you might get away with no cost measure. So that's kind of a nice way to participate in those. But again, it's somewhat limited in terms of the specialties as we're really sort of getting this rolling. So you'll just have to look and decide. The nice thing is, as Mike said, for this year and for next year, you can pick and choose which MVP you want to use. And there's some of these that are pretty generic. Promoting wellness, and there's a women's health one, I believe, that's coming out next year. So some of these are a little bit more generic, I'm going to say, where you might be able to do them even if they don't align specifically with your specialty.
Great, thank you. I did see one on here that I wanted to get an answer to, but how do you determine if the patient cost is attributed to you as a provider or another physician, or can costs be attributed to more than one provider?
Costs can be attributed to many providers. The way CMS does it for a lot of the measures, it's any physician or any clinician or group that provides at least 30% of the E&M costs. So in many cases, a particular patient or episode could be attributed to as many as 3 different clinical groups.
Great. If we didn't report last year and don't have cost data, so they weren't able to see their cost data, is it still worth exploring MVPs?
Sure. Not only from the cost perspective, but also from the quality side. As I said, you're only having to work on 4 measures. And, you know, we see from the JAMA article that the average practitioner spends about $12,000 reporting. We feel like if you're parsing down from 6 measures to 4 measures, that there is less effort involved, and who doesn't like to save time and money?
There was a question in here about there only being 4 measures in quality, and how does that equate to score? I think you did hit on it, that the 4 measures are 6. It's just a larger number that's taken for the math. If you could explain that real quick, that'd be great.
So your quality component is always what it is. And, for most people, it's a 30% of your MIPS score. So that 30%, if you are doing traditional MIPS, you have 6 measures. So your denominator is typically 60, and then you add up all the quality, all the decile points for those 6 measures, and then you scale that back to 30% of your score. If you're only doing 4 measures, you do the same kind of math where your denominator is 40, and then you add up all of your performance data from those 4 to get your numerator, and then you scale it to 30% of your MIPS score.
And that's also the same case in cost as well. I see a couple questions about that. If you have 2 measures where you get a total of 16 points, you take that and then it's 30% of your score. So you're multiplying that 16 times 0.3, which will get you 24 total points. So that came up a couple times in here. Is reporting an MVP for 2023 a full year?
Yes.
Okay. Yes, that's it. That's all you get. Yes, it is. It's the same exact thing as MIPS currently is, still with PI and IA being at 90 days. We got that one. What year date range does CMS look at diagnoses to determine the risk adjustment?
Oh, so it varies by measure. So depending on the measure, there's a look back period, and that look back period can be up to a year for some measures. And it's a year from the start of the episode typically. So, and in some cases it's less. In some cases it's 30 days. In some cases it's 90 days or 180 days. It really varies based on the measure.
Great. I had a good one in here, and I don't know if I asked it 100% yet, but for cost measures, we know that some of them have the ability to be split between different TINs. The attribution for one patient can be attributed to different TINs. Can you explain how that works? I know it's a little bit different for each one of the measures, but different TINs can be attributed to the same patient for, like, I think it's MSPB. They could all have the same patient if they were part of it 30, as long as they do 30% or more.
Right. So if there's a patient that is in the hospital and more than one, each TIN that provides at least 30% of the E&M billing will get that episode attributed to their practice. So that's where I'm saying that one patient, the full cost of that one patient will get attributed as an episode to each one of those potentially 3 practices. And I know that's, super high level and super confusing. If you want to talk through that a bit more, feel free to give us a call and we can help you walk through it. I know some people are operating at a very new understanding, and some people have a lot more sophisticated level of understanding. We're happy to talk through that with you guys.
Is there any other ones that stood out to you, Lauren, that you wanted to get to today?
I don't think so.
All right, great. Well, everybody, thank you once again for joining us on today's call. This was a lot of great questions, and we'll get to more of them as we have some time later on today or by early next week. But once again, remember, you give me a call and we can get you in on our MIPS cost analytic tool so that you can start utilizing our product ASAP. Have a wonderful day, and Lauren, thank you very much for all of your input.
Thanks for organizing, Mike.
You got it. Bye-bye.